Hey, welcome to Health or Hoax. This is part 2 in a 3-part series regarding the LANCET series of low back pain. Part 1 discussed the nature of the problem. Part 2, this is going to discuss a lot of the possible treatments and misconceptions around treatments for low back pain. My name is Anthony Davis. I'm joined, as before, with Blake Loxterkamp and Dan Brown, who are classmates of mine as chiropractic students at Northwestern. So we're trying to understand low back pain, and hopefully this can help you understand low back pain a little bit better. So quick points. I'm just going to give a really, really quick summary of the whole paper, just the main bullet points. And then hopefully that's interesting enough that you stick around and listen to maybe a little bit more details. So right off the bat, we look at, throughout the paper, they're talking about different, expectations for patients going to emergency rooms, things like that for low back pain. Looking at the evidence-based guidelines on how to manage low back pain, the following are recommendations for managing low back pain. Low back pain should be managed in primary care. People with low back pain should remain active and stay at work. Imaging, like x-rays, MRIs, should only occur if the clinician suspects a specific condition that would require different management to non-specific low back pain. Education and advice is important. The first choice of therapy should be non-pharmacological. So drugs should not be the first choice for therapy. Due to unclear evidence of efficacy and concerns of harm, the opioid analgesic medicines are now discouraged. Most guidelines advise against electric physical modalities like, there's a bunch of them, E-stim and shortwave diathermy traction and all those types of units. Exercise is recommended for chronic low back pain. Interventional procedures and surgery have a very limited role, if any, in the management of low back pain. A biopsychosocial framework should guide the management of low back pain. Now, with that said, a lot of those points, I think, contradict a lot of the sort of common wisdom around low back pain. Obviously, because patients are seeking care in the wrong places, and clinicians are giving care in the wrong ways. So what I'd like for all three of us to do, Blake and Dan and I, is we're just going to, in 10 seconds or less, we've all read this paper, and just give, in 10 seconds or less, just the headline, why does this paper matter regarding low back pain? So I'll start us off in 10 seconds or less. This paper is important because low back pain is the #1 cause of disability in the world, and we are totally fucking it up. And there's no reason for us to do that because we have good guidelines in place, but we're just ignoring them, or we don't have the framework to deal with it. And this explains how. So that's my takeaway.
My main takeaway was that the best treatments for acute and chronic low back pain are education and physical activity and or exercise. So if you're going to treat low back pain, you should be really good at those two things. And then if you want to add in some of these secondary therapies like spinal manipulation or acupuncture, that's fine, but you have to have that core of exercise and education.
Yeah, my takeaway from this paper is that we need to grow as a profession in doing this better, doing these interventions a lot better. Stress produces adaptability, and adaptability is how we survive. So this paper is all about adapting to what's in the future.
Great. Now let's, I think last time we ran a little bit long, so we're going to do our very, very best. I put the onus on myself and you guys keep me on track. We're going to try and do this quickly. We'll fly through this paper and just main highlights, but maybe a little bit more detail. We'll talk about all the same things, the bullet points that I just mentioned, but expand just a little bit on why those are important and maybe what we can do about them. Again, if you're listening to this and you think that we're misinterpreting something, or you disagree, or you have questions, or want to add to the discussion, please comment. We're trying to understand this. We're trying to help you understand this as a listener. Clearly, the whole world and all kinds of doctors, chiropractors, physical therapists, medical doctors, osteopaths, everybody is sort of fumbling this ball. So nobody is essentially getting it right. So, let's keep that in mind and stay humble here. So, basically, as we've highlighted before, there are substantial gaps between evidence and practice, and we need to close those gaps. Now, that means that we have evidence. We don't have the very best evidence in the world that can tell us this method is going to cure this person's low back pain. We don't have a perfect system, but we do have good evidence to show that certain methods work much better than other methods. And unfortunately, clinicians are just not following that advice. Does anybody have anything to add to this page?
I found it very interesting with prevention, because obviously that's the next subtopic that the paper talks about, is that there isn't much out there for prevention of low back pain. There isn't a lot of evidence for or against, except for, we'll see it on the next page, maybe some exercise and education, but education alone is ineffective. And so I found that very interesting in the prevention portion of this paper.
Was it referring to chronic low back pain, or just, because I would say that, I don't know, acute low back pain is kind of just part of being a human. Like,
correct.
You're going to have back pain occasionally.
Mm-hmm.
I think the big thing for us and what we should care about as future clinicians is preventing that acute low back pain from developing into chronic low back pain. I think a lot of these treatments kind of point towards doing that.
Yeah. They make a very clear point about how low back pain should be managed first. Like, what is the first thing you should do for low back pain? Well, I guess the very first thing is that you should weed out, that you should, if you're dealing with a doctor, or if you are a doctor, weed out red flags, make sure there's nothing serious going on. And as long as there's nothing serious that requires a really specific type of intervention, then there's this paper outlines and brings into play several different guidelines for management of low back pain, and what should be your first option. And then if that does not work, then what you should do afterwards. But that's coming up in this later, I think, in this paper. So on the next page, let's see here. I guess I was curious to see this, or it was interesting for me to see this, that, even, I'm definitely biased towards thinking that exercise and education is the best way to go in general. And, it does have moderate quality evidence, but that's it, right? And nothing has high quality evidence in terms of the prevention strategies for low back pain. So in terms of prevention, when they looked at exercise and education, each of those alone, using back belts, shoe insoles, ergonomic workplace interventions, ergonomic furniture, things like that, nothing had high quality evidence. So we just have crappy evidence on the prevention of back pain. Later on, we find that we have, I think, some better evidence on how to deal with the back pain once it arises, but actually preventing it, we just don't have good evidence.
Yeah, and back to Blake's point about that, I mean, low back pain, being that it's the number one globally known issue, right? It's going to be a part of life. And that's, I think, one of the parts of education that may help prevent, but especially when it comes to this next part that we'll talk about with treatment, is vital in saying, just like degenerative disc disease, we've talked about this numerous times, where like it's a normal process of aging. It's a normal process of being a human. It's okay that this is happening. It like we talked about last time, it will resolve in roughly 6 weeks, depending on the situation for that individual.
Yeah, and I don't think it would be. I think it'd be harmful if you went to a provider and they were like, "Oh, it's not normal for you to have
Right.
pain. You're doing because the underlying tone of that is like you're doing something wrong. You're doing something harmful to yourself that's causing this, and that's just not true. Like you get aches and pains. That's part of being human.
Right.
Yep. So important highlights here. A greater emphasis is now placed on self-management, physical and psychological therapies, and some forms of complementary medicine, and less emphasis on pharmacological, like drugs, and surgical treatments. Guidelines encourage active treatments that address psychosocial factors and focus on improvements in function. So there's a graph that I've seen a lot lately where basically if people start off on their therapy and they're focused entirely on pain rather than being focused on their function, we can improve function a lot faster than we can improve a person's pain. So if you're obsessed with pain, well, you might start off in the first, weeks of therapy and your pain might not change much. And you might be ignoring, as a patient, you might not focus on the fact that, well, yeah, your pain has remained unchanged, but yet you can do all these things like that you couldn't do before. So you can function better. You can now garden. You can, use a wheelbarrow. You can pick up your kid. You can do groceries, whatever. And so I think focusing on the fact that we are helping people to improve their function is a really important thing, rather than being obsessed with pain, which I think is why there's such a heavy reliance on drugs and surgery, is because and manual therapy, by the way, because let's think manual therapy is just a painkiller. Yeah. So I think that's why we're so into those things, is because doctors and patients alike are really obsessed with pain. But what about function? It says we should focus on function.
I think a lot of that obsession with pain comes from the misunderstanding that because something hurts, it's causing harm.
Right.
Yeah. Yeah.
And because a lot of, like, if your doctor tells you that, your back hurts, so that, and if you don't change something in 10 years, you won't be able to walk. That's just blatantly false. We have no evidence for that. Mm-hmm. There's no way you can predict that. And we know that pain's not associated with harm. So the biggest association with pain, I believe, is like fear.
Yep.
So I don't know. I think if we keep working on changing that paradigm, which would take a huge cultural shift in thinking,
yeah,
that would probably help. Not super easy though.
So we have, this is like a big headline, really big takeaway. I think, this is the big picture, is the U.S. guidelines, which recommend non-pharmacological, again, that's just not using drugs, as the first treatment option, and reserve pharmacological, aka drugs, care for patients for whom non-pharmacological care has not worked. So you got to try not using drugs first. And these guidelines are endorsing the use of exercise. Well, that doesn't make any sense. If you think that hurt equals harm, if you think that when you feel pain that you're harming yourself, then exercising through the pain doesn't make any sense to you. So this is where really educating clinicians, I mean, we're getting the wrong message in school, in my opinion, and then educating patients, because most patients, when you ask them where they got their belief that pain equals harm, they got it from their doctor, and their doctor got it from their school, or their teachers. So it in my opinion, I think a big part of it starts with the schools. But let me just finish this quote, and then I'd like to hear from you guys. And so the guidelines endorse the use of exercise and a range of other non-pharmacological therapies, either alone or in combination, such as massage, acupuncture, spinal manipulation, Tai Chi, and yoga. And just one last comment on that is that I was surprised to hear that, I was going over this paper with some other individuals, and they were kind of shitting on, acupuncture or this or that. And it's like, that doesn't seem useful to me. I think the bigger picture is let's not use drugs and surgery right away, because that has really good evidence to show us why we shouldn't do that. And maybe we should stop squabbling over, well, my, soft tissue thing, or acupuncture. Well, Tai Chi is bullshit. Is it? It's better than using opiates.
Mm-hmm. Yeah. Yeah, no, I agree with that, because there's a contextual thing, and again, we've discussed a lot about that. There's a contextual component to the healing, right? Being alternative healthcare as sometimes a secondary option for people. People have been recommended Tai Chi or yoga. I know quite a few doctors that I used to work with in the hospital did recommend that to their patients coming out of the hospital. I have a friend in PT school right now who this Tai Chi yoga stuff, this more alternative types of movements, is helping a lot of people. And so just to deny that as a contextual component to the person's healing isn't probably the best thing. I don't know I wasn't a part of that discussion that you had, but we have to remember that the patient's goals matter. So if the patients have heard that acupuncture is good for them, it may be a good goal for them to try it, to see if it helps them to heal faster. Doesn't mean it's doing exactly what we think it's doing, but it does mean that patient has something that they're doing that is for themselves, that they do think is good for them, and then they are getting better as a result of that. So
yeah, I think as long as these passive modalities are used within the context of trying to get you to move and exercise and do the things that are important to you, and that the narrative surrounding them is positive, as far as we're doing this, adjustment to, relieve some pain so that you can go and walk or go and squat, or we're doing that, or using acupuncture to do that. Not, I'm using this adjustment to fix your misalignment,
right.
or I'm using this acupuncture to break the adhesions in your body or something. Because that's taking the power away from the patient.
Right.
Because then if I think I have all these adhesions, or all these my spine is misaligned, then you're going to tell me to exercise, and I'm going to be like, no, my spine is misaligned. But
you just told me my spine was broken. What?
Yeah. You want me to go put 100 pounds on my back? What is, you're an idiot.
Yeah.
Right.
So
yeah.
If you use them as a bridge and continuously encourage the patient while you do that, I think they can be a really useful tool in getting someone from being sedentary and in pain to active. Because that jump from being sedentary to active is not an easy one to make for a lot of people.
No, not at all.
Okay, so right here we've got let's make one point at a time. So first, exercise. There's not really good evidence saying that oh, running is the best thing, or swimming is the best thing, or you got to do weightlifting, or you really got to do McGill's Big Three. That's what's going to do it for low back pain. There's not really good evidence saying that one is especially, is going to fix all your patients or fix everybody. So that in mind, it's not that, biology doesn't matter. It's not that structure doesn't matter, but it's that we haven't found the answer yet, if there is an answer like that. And so given that, in the meantime, at least we can focus more on the individual needs and preferences of the patient. So if the patient likes hiking and they're going to do it, then just tell them to go hiking.
Yeah. Yeah. The biggest thing for advice as a first line treatment, if you go to the next page there, Anthony, right at the top of this chart here, the first line of treatment to consider as a normal routine is advice to remain active and education for acute and chronic low back pain. So it's like, this is not something I've ever seen beyond maybe one or two chiropractors that I've shadowed, right? This is not something. I worked for a chiropractor for a year, and at certain times, they definitely said this. They were like, be active, move, or get going. But right away, they're like, yeah, you should probably ice this and just ice heat. And it's like, all right, that's fine. That's helpful for pain management to some extent. But how do you get them to do that for themselves, right? How do you get them to be the superhero in the story? And this is not being done. This is not what we're being taught in school.
Yeah,
right.
And I really don't, at least based on this paper, I don't think any profession is doing this.
Right.
No, everybody's
our profession, but yeah, I agree.
Yeah. No, and in the paper it tells us that every single profession is fucking it up. They're all doing okay, so we just looked at this. What are the first line treatments? Advice to remain active, education, exercise therapy, cognitive behavioral therapy. Yeah. So these are all the first line options. When you have back pain, this is the first thing every clinician should be doing, is some combination of these things first. And only once they've tried this and it failed, then they should do other things. But what is actually happening is, what are we doing? We're doing opioids. We're doing, steroid injections right here, epidural injections.
And they're not.
And
they're not recommended.
They're straight up not even recommended. Not even as a second option. They're just straight up not recommended.
Yeah.
Right.
And I just, for people who are watching this that don't like, I don't have a PhD or anything. I'm not an expert in research. I just happen to read research a lot. But for people who don't do that a lot, in research, in my experience, it's like everything is really shades of gray. It's like, oh, well, there's insufficient evidence, or, oh, we really need to do more research. So to see somebody specifically say not recommended, that is a very bold statement.
Yeah.
For research. That is a bold, that's like, yeah. Anyway.
It's the creme de la creme, right? It's like the...
Yeah, I kind of expected all of it to be like role uncertain or needs more research.
Right.
Yeah.
I mean,
but it's...
You look at anti-seizure medications or muscle relaxants, like even muscle relaxants are limited use, right? Yeah. Or there's insufficient data in that, but the corticosteroids and the epidural injections, like, it's not recommended. I agree with you. It's very like, this is not the best treatment.
Yep.
Which I think really like is kind of exciting for like practitioners like chiropractors and physical therapists, because we can do all or most of these like first line and second line recommendations. Mm-hmm. And we are not allowed to prescribe medication. So we don't have the ability, like there's no temptation to use those because we don't have the ability to use them. Patients won't ask us for them.
Right.
So if we adopt these first line recommendations and use those and just add in these second line ones as needed, but not as our primary one, like I really think that that's a cool place to be in. But we just need to not do these second line ones only, because then we...
Right.
Which I think is what a lot of people do. important.
That's a really important point. I was waiting to bring that one up, which is that, so yeah, okay, medical doctors and osteopathic doctors, at least in the United States, osteopaths are treated the same as medical doctors, so they have the same scope. So those guys are all prescribing drugs and doing injections and things like that, which is totally against the evidence. But as you said, we don't have the temptation because we can't. We're not allowed as future chiropractors, and physical therapists would be the same deal. Now, but what we do is we jump straight to the second line options. Here are all your second line options that are within the scope of chiropractors and physical therapists: spinal manipulation, massage, blah blah blah. Rehab, stuff like that. Mindfulness, whatever. So all these things, these are the things that, especially the spinal manipulation, soft tissue stuff, these are the things that PTs and chiros jump straight towards.
Or ultrasound and crap that they just said do not do.
Yes. Yo, thank you for pointing that out. So right here, some guidelines do not recommend passive therapy. This is important. Do not recommend, well, yeah, this is funny to me. Some guidelines do not recommend passive therapies such as spinal manipulation, mobilization, massage, and acupuncture. Some consider it optional. Others suggest a short course for patients who do not respond.
You're being very diplomatic there.
Yeah. Some people think it sucks. Some people think it's okay. Some people think it's great. But here's the thing. After they just made a statement that's very let's appease all the studies, they made one statement that was very clear as day, which is other passive electrical or physical modalities, such as ultrasound, transcutaneous electric nerve stimulation, traction, interferential therapy, shortwave diathermy, and back supports are generally ineffective and not recommended. We just finished an entire trimester of learning about these stupid, ineffective methods.
We're not done. Why are we wasting yet either, though?
I know, and he's all right. Let's not.
Yes. Anyway, but what's so interesting is we have a whole license board exam on these modalities.
Yeah.
We cannot become a chiropractor without knowing about or being tested about these modalities. They're ineffective and not recommended. It just boggles my mind. And I love the idea of it, but it doesn't work. I'm not going to use it.
Yeah, it feels nice.
Yeah.
Right. And they talk about PTs later somewhere in this paper, and they're like, physical therapists are in a great position to use education and exercise. Unfortunately, a bunch of them use passive electrical modalities.
Correct.
Yep.
It's fun. I think it comes down to it's fun to play with this machine. And it's easy,
right?
Because
it's theater.
I can train a CA to use it, and I can make money while I'm not in the room.
Exactly, and it's placebo. It's the ultimate placebo. I shouldn't say the ultimate, but it is a placebo for the patient too. Oh, something is being done to me. This adds value, theater to it, and now thus it makes it better. Well, no, in this case.
All right, let's move on. So. This is a quick passing note. We just don't have a lot of research on back pain for children, so I that's where I'm going to leave it. We just don't know on that one. So if you want answers, go talk to your doctor, or if you're a doctor, I don't know, read more research.
Go talk to a smarter doctor.
Yeah, exactly. If you're a doctor, go talk to a smarter doctor. Anyway, next. So let's see here. Yeah, this is what you were saying. They're in a. Yeah, here we go. This is the stuff. It's like, okay, so yeah, what Blake you just said. Physical therapists are in a great position to provide care, but then when we actually study it and we see, well, what are physical therapists actually doing? They're using electrical modalities that are ineffective.
Yeah.
So we know better.
Yeah.
We have the scope and the training to do better. And then we just don't do it.
Yeah. And that's the beauty of this paper, is that it's literally being like, hey, stop doing these things. It doesn't make any sense. And that's why the paper series is so great. Is it's literally putting it out there for everyone. Now they have no choice but to look at these things.
Yeah.
So right here, so we're overuse of low value and underuse of high value care. So there's a big debate amongst the groups that I'm in with chiropractic students and chiropractors. And there's a lot of debate because a lot of people in the chiropractic world are pushing back against the use of manual therapies. They're calling manual therapy low value care. And then there's a pushback against the pushback that says, no, fuck you. Manual therapy is not low value care. It depends. Well, maybe we can sidestep this issue and again take a big picture kind of view and go back up to this chart and realize, what is the big picture? If I look at this chart of all these different treatments for low back pain and I say what's low value and high value, I see the ones that say explicitly that they are not recommended, like drugs and injections and surgeries and things like that. Those are low value. They are explicitly not recommended. All this other stuff, yeah, it's versus, it's first line versus second line treatments, but they're all at least a viable option. So I think that maybe we can get our, priorities straight and say, yeah, spinal manipulation shouldn't be used as your first line, but it's not low value. It's just, it shouldn't be it's low value as a first line treatment. Right. Maybe that's a more nuanced approach. I don't know.
Especially if that's all you do, right? Just do more than one thing.
Right, exactly. Yeah. Rachel Balkovec was just on the webinar with Craig Liebenson here earlier this morning, and she said something that was fantastic, piece of advice that was given to her. She's like, her mentor's like, don't be a guru. Don't get stuck in one thing, because then you're not going to be able to help anyone. Be adaptable, be variable. We hear all the time at school, have multiple tools in your toolbox. Do something else, not just one thing. You're going to help so many more people with that way.
Yep. So, okay. So this is about the point in the paper where I started thinking, do we, because clearly individual doctors cannot be trusted to follow or read or follow evidence.
Yeah.
And maybe
supporting your point, the point they made later on that like choosing wisely literally did nothing to the use of x-rays. The percentage of x-rays for low back pain stayed exactly the same.
Yeah, 53.7%.
Choosing wisely was saying like, we need to not x-ray so much.
Yeah.
It's like,
and it was big and popular, and a bunch of people knew about this, this whole thing, and yet nobody changes what they're doing. It's awful. Well, but then, and so let's think about that for a second, because it also, what about when we think about giving advice to patients, and we give this advice and we say, oh, you should change your lifestyle. You should start eating different. You should start getting good sleep and do this and exercise and blah, blah, blah. And, well, how often, and I know we get a lot of this pessimism of like, well, if you try to change a person's lifestyle, it's just not going to happen. People aren't going to change. Well, sometimes they will, sometimes they won't. I don't know. Maybe we should keep doing that. We should keep trying to get individuals to change when possible, and make good choices. But I think the more effective thing is that, as is quoted here, is initiatives are urgently needed for policymakers to make decisions that are more in line with best available evidence. We need a top-down approach that is implemented so that the insurance reimbursements are based on following the evidence, not on how many people you can jam into 15-minute appointments. And I don't even know enough about insurance billing at this point to know all the other. I'm sure there are a million other problems with the reimbursements and all that. But we need policies in place. We need reimbursements to be different. We need to design the environment to be more constructive. Like I'm pretty sure, like in schools, give people more breaks, time to walk around, encourage activity, stand-up desks, stuff like that. I mean, there are probably a million ideas that you could try to implement. And if we attacked that thing from every possible angle, then maybe we might move the needle.
Right. There's something that you said just now that I would like to address. I think I don't remember the exact verbiage, but you said something along the lines of like, oh, changing lifestyle is really, really hard, and so some people don't do it, right? So some people, and I think as healthcare practitioners, if we think that that person can't do it, we're already limiting their healing, right?
Yeah.
That comes back to the cognitive behavioral component, right? Like if we as practitioners think this person can't do it, we've shut down that person's healing right then and there. And I think in schools, if they could start teaching people, hey, as a top-down pursuit is, hey, let's start teaching students to see every patient as someone who can do these things. We hear all the time, oh, 80% of your clients are never going to follow a workout program or a home exercise program. Well, that's because you think they're not going to.
Yeah, that's because you think they're not going to, and maybe you really suck at exercise programming.
Right.
Because it's not as easy. It's not an easy thing. Like it's something you need to study and get good at.
Right.
That's like if I don't know, like in a drug rehab setting. If the people doing the rehab really suck, people won't get better.
Right.
Like you need to be good at what you do, and you need to believe in the person that you're treating.
Yep.
And people will make big changes. It just takes the right stimulus.
Yep. 100%.
So, despite all of this evidence, we still see that both on the patient side and the clinician side, people are just dropping the ball. Patients don't know better, so we see that when we look at globally, we're looking at what do people do when they have low back pain, and we see that many people go straight to emergency departments for their back pain. We see that it is not uncommon for people with low back pain to present to the emergency department and then stay in the hospital for several days. Mm-hmm. From the doctor's side, there was a South African study that showed that 90% of patients with low back pain seen in primary care received pain medicine as the only form of treatment. Again, we know better. We have guidelines in place. They are not being followed. So what are the difficulties? There are some key challenges to implementing best practice, and that includes that we have short consultation times. Clinicians have poor knowledge of, and they have misconceptions about clinical guidelines. So the doctors themselves are poorly educated, and they don't know better. There's fear of litigation. If you miss something, God forbid you miss something serious with a patient. So let's just get the x-rays. Let's get the MRIs. Let's do the drugs. Let's do the surgeries. Let's whatever. So I don't know what that's like. I'm not in practice right now, but I understand that would be that would be a fear. You don't want to miss something. Right. I get that. You don't want to just treat everything like it's this, non-specific, it doesn't matter. Do some exercise, whatever. It doesn't matter. So that's tricky, but there are a lot of hurdles.
I think a point to make is because I hear somebody saying then like, well, why not just get the x-rays? Because then, you'll know, and if there's nothing wrong, then, all is fine. That's not really the case, because if you get an x-ray, you probably will find something. You'll probably find like osteoarthritis or some kind of congenital anomaly, and then for the rest of your life, like that's a part of you. And if you don't know any better, you're going to associate that with like pain or fear or like getting x-rays and knowing about things like that is heavily correlated with worse clinical outcomes. Like you don't want to know.
Right.
Like,
ignorance is bliss, right?
Yeah. I mean, every time your neck pops, I've worked with clients as a personal trainer who every time their back pops, they think it's their spondylolisthesis sliding forward on their spine. And then they're like, I'm done doing exercises for the day.
Yeah.
It's not great.
And just to be clear, it's not advised that ignorance is bliss sort of thing. It's bliss. For those who don't know this, who are watching, it's bliss because if you take an x-ray of a bunch of people who have no symptoms, you're going to find a bunch of stuff that looks bad, but it's not causing them any problems. So you can live a healthy, pain-free, functional life And even though an X-ray looks bad, it's not necessarily bad. So that's why sometimes if it's not broken in terms of function, don't fix it. Okay, so we've got these. This is a whole table full of basically attempts to implement new strategies, top-down sorts of strategies, and how successful they were. Essentially, it's good to see, integrating doctors with chiropractors. As long as chiropractors can be good team players and not,
right,
think that they have the cure-all. Because if we went to that table on page 2 of this study, remember, chiropractors, spinal manipulation was a second-line treatment, so it's fine, but it's not going to fix everybody. People can improve in function and return to work even if pain remains. And evidence shows that return to work occurs before symptom recovery. That ends with fewer disability days, earlier return to work, reductions in the use of healthcare. It's more cost effective. All these things, all these reasons to encourage activity.
Yeah, if you go down that section there towards the bottom, it's just above your little highlight there. There's this multi-system study that was done in Denmark, and the return on investment for those individuals that went to work sooner was 26 pounds to every 1 pound invested with the usual care. And that's if people are looking at this from like a society component or a socioeconomic component, if you can get people back, especially these lower income and middle income societies that the paper talks about, imagine how much better off they are and how much more freeing it is for people to get back to work. I mean, COVID-19 at this point in time, my wife is a landscaper and her work hasn't been shut down, and she's really itching to get back to work. Now, she's been sick a couple times now, so she can't, but for her life and her goal in life is to be a good worker and to do well at her job. And for her to have those things, it makes life so much better for individuals.
So again, another message here. We've got a further promising direction could be to target both the healthcare system and, more broadly, public health through integrated healthcare and occupational interventions. So again, if we have policies in place, we look at if we create an environment that makes it impossible to not succeed, then people succeed. It's like there's a human-centered design principle that there's no such thing as user error. Like have you ever gone and tried to use a door, one of those double doors, and you go and it's got the clasp on it, like it's got a handle, and since it's got the handle, you pull the handle, but it's a push door, so it's got a handle. You try to pull it, and you think, oh, I screwed up. I didn't read that it says push. Well, if it's a push door, it shouldn't have had a handle. It should have only had a flat surface for you to push. So you create an environment where there's no option. You can't fuck up. You can't pull the door. So you just create a better door, and then people don't have any choice but to succeed in adopting better interventions. So there's a ton of information in here about financial incentives. This is the other thing that it just doesn't make any sense to me, because why these interventions haven't been more widely adopted and implemented and embraced, because it makes sense on every single possible level that I can think of. It makes sense in terms of patient outcomes. Patients will get better if people are following these recommendations. It is way more affordable to follow these recommendations. It's not just more affordable, though. Here in the U.S., where we're super privileged, right? This happens to be that the better treatment for low back pain is the less expensive one. So it makes sense in terms of cost, and it makes sense in terms of patient outcomes. I mean, it makes sense on every possible level, and yet we're not adopting it. What is getting in the way? So, we need supportive laws. We need policies. Interestingly, changing payouts for disability and decreasing payments, et cetera, increases patient outcomes so that they are less disabled. They're less likely to try and milk the disability. And when we try to, it's somewhere in here, but essentially financially incentivizing people to return to work. It's not that it just gets them back to work and that they are suffering through their pain in order to get the money from working. It's that they're back to work, they get the money, and their pain is less and their disability is less. Right. So it's like a win-win-win situation. Right. We're not just telling people to like tough it out, deal with your pain. Your pain doesn't matter. It's not what's happening. That's all the main points throughout that I have highlighted. Did I scroll? I scrolled through a lot of stuff there, guys. So were there any other points in there that you guys wanted to touch on?
There was one, and this comes back to the red flags. Let me get back up to that area in the paper here so you can scroll up to it here. It's on page 4, towards the top left. Coming back to working as an integrative healthcare system, there are these times where referral and surgery are needed. So like back to the part 1 and in this, these treatments are for these non-red flags. I think it's still important to remember that there is a place for this integration and this referral-based system that needs to happen. You need to have a relationship with a good orthopedic surgeon. You need to have a relationship with a general practitioner that you can refer your patients to, because if you don't have those connections, if you don't have that relationship with people, you're missing out on so much more that resources for your patients. And so there is a place and time. The paper states patients with severe progressive neurological deficits require a surgical referral. So having those resources for those patients are very, very important. That's one thing that I really liked about this paper that we didn't talk about.
Yeah. Yeah, I think we mentioned this last time, but it's important not to get lulled into this. Although with 95% of low back patients are going to be, like, let's exercise, let's get you back to work, let's, get back out there, and that's the best thing to do. Encourage that. That doesn't mean that 5% of the people don't legitimately need some more serious interventions, and we need to make sure to obviously catch those. But just put it in perspective. It's 5%, so it's not that it's not that it's nothing, but it's also, I don't know. It's hard, got to get that proportional, I guess.
Right.
Yep.
Maybe so. Maybe, I mean, this is what it mentioned earlier, is that like if people are so afraid to miss these that they treat everybody like they're the 5%.
Right. Yeah, that's all I had, though. I mean, this paper was fabulous to read through. So for those out there who haven't read through it and are healthcare practitioners, please read this. This is what we need to be pursuing.
Yeah. I mean, some very good evidence-based MDs are part of a company called Barbell Medicine, and this was like one of their 5, like, if you're a doctor, like, they're referring to MDs, but like this is one of the things you need to read. Like, you need to know this.
Yep.
So, especially if you're a chiropractor and you claim to be a back pain expert, like,
Yep.
You should read this.
Yeah, I agree. I don't think I've read a more concise and important series of papers is that, well, this one, because it summarizes the treatments. If you had to pick just one of the 3, it seems like this would be the one.
Right.
Yeah, cool. Any other closing thoughts, guys?
No, I've said my piece.
Don't fall in love with the treatment that's not evidence based. I empathize with, like, you know, if you like with these chiropractors who spent all this time getting really good at spinal manipulation, like, you don't need to stop doing that, but like,
Right.
just do the other thing, do the first line treatments.
Yeah.
Also.
Yep.
Yeah. Do the first line first, and then if it doesn't work, then do the other stuff.
Yeah.
And even if you wanted to, I mean, it did say secondary. You can adjunct it as well. Like, if you know that this patient has had this issue in the past, and a manipulation helps them get better faster, just use it, right? Don't be afraid to use it either, but don't use it as the only thing.
Yeah.
Fair enough. Cool. Thanks, guys. Thanks for joining us, to our viewers. Like, subscribe, do all the things. See you next time.